Without further ado, what I'm going to do now is introduce Tom Wilson. Tom is going to speak on accountability solutions. And as I mentioned beforehand at the beginning of this, Tom, in addition to his many things, is the founder and the chairman of the board of the Population Health Impact Institute. PHII Institute is a non-profit organization that's been dedicated to impartial, independent, and transparent comparisons of different evaluation methodologies and different defined population health management programs. So, without further ado, Tom, let's give credit where credit is due.
Thank you, Bill. Thank you, Bill. Can you hear me? Yeah, great talk, Mike. And I think one thing that we're going to talk about for the next 20, 30 minutes is really defining what we mean by accountability to a certain extent, because just the fact that I'm accountable for something doesn't mean I'm responsible for the actions that I have. And I think what we see in healthcare is a lot of people who are not necessarily responsible for successes or failures in healthcare are getting rewarded for those successes or failures, or getting blamed for that. So what we're interested in with this quality evaluation process is giving credit where credit is due. My Aunt Mary used to say about her sister, she knows the price of everything and the value of nothing. And I think what we have in healthcare, we often even don't know the price of anything. But even if we do, I think the consumer often thinks that the price is related to the outcomes that will occur. And we actually don't know that. And in fact, what we saw with Michael's talk, there may be a reverse correlation between them. But this quote points to two overriding issues that we're extremely interested in. One that Joel brought up, which is transparency. Show your work, how did you do what you're doing, and quality. We're all interested in quality. But the quality that our group is interested in is the quality of the evaluation, the quality of the methods used to make claims of success or failure. For example, just the fact that a hospital shows that they've reduced their morbidity and mortality for a certain procedure does not mean they're 100% responsible for that. It could be the physicians at the hospital. It could be some other quality efforts going on inside the community that were not directed by the hospital. It could be patients becoming more intolerant and so forth. Now, what this is all about is a conceptual slide that just came up with the other day because it seemed to work. We're interested in a pathway between an intervention and an outcome, between A and B. We do A, we think B happens. And we want to, what outcomes assessments are all about are measuring B. And just the fact that B happens doesn't mean that A is the cause of B. And so we've got to look at C. And a lot of things that happen, I know in my world, disease management and wellness, a lot of the people doing A are taking all the credit for B's, when in fact there may be physicians in the community, there may be other efforts, C's, there may be all sorts of things going on that could be affecting that pathway. And for people to make attribution that they, A, were the cause of B, they have to take into account the other factors and be honest about it and know that they aren't responsible for everything that happens or are blamed when things don't happen. This is a slide from the Congressional Budget Office report from a few years ago about disease management, and they laid out here on the left the pathway that a disease management diabetic program should take. There's an intervention, including education, selection of patients, there are process outcomes, what exams, eye exams, and so forth, intermediate outcomes, health outcomes, quality of life, healthcare utilization, economic outcomes. And this is a very typical way people are thinking about a pathway. And it's perfectly reasonable. It makes a lot of sense. I call it a hypothesis. This is what we think is supposed to happen. But just the fact that economic outcomes occur doesn't mean that those economic outcomes were related to that disease management intervention. So on the right side here, which is from our institute, It's showing a conceptual pathway between what we call the type 1 metric, which is the intervention, a metric related to the intervention itself, a type 2 metric, which is like an intermediate outcome, for example, hemoglobin A1C screening, hemoglobin A1C levels in the diabetic population, and a type 3 metric, meaning an ultimate outcome, the thing that you're really trying to change, which might be patient status or quality of life or whatever. Well, that's the pathway, type 1, type 2, type 3, but you've got to look at what we call type 4 metrics, which are these other external factors that are almost in every case, not all cases, almost every case, these are factors that are influencing this pathway that are generally ignored. And this is just that same diagram on a horizontal axis. We call type 1 metrics program process metrics, type 2 proximate outcome metrics, and type 3 ultimate outcome metrics. Type 4 factors that can disrupt this pathway, confounding variable metrics. Now, there are some cases where confounding variables have a tremendous influence, and some cases where they don't have any influence at all. This is a predictive model. Basically a stone hanging, this is at an airport. Gary's forecasted, weather forecasted stone, says if the stone is wet, the forecast is rain. If it's dry, it's not raining. If there's a shadow on the ground, it's sunny. If it's white on top, it's snowing. Can't see stone, foggy. Swinging stone, windy. Stone jumping up and down, earthquake. Stone gone. So it's a wonderful predictive model. Unfortunately, there are so many other factors, right, that could be indicated by the status of that stone that have nothing to do with the outcomes that the stone is predicting. And we think this is so there's a lot of confounding variables in this particular pathway. Now here's another example. I know you can't read, I'm showing the article in total because this is from British Medical Journal, reputable medical journal, complaining about the lack of evidence for the effect of parachutes. Say they went through the literature, the exhaustive search of the peer-reviewed literature, and found no double-blind randomized clinical trials for the effect of parachutes. And they were complaining about that. And they said, we have no reference group. We don't know what would have happened in the absence of parachute. Well, obviously, it's a joke. But in this case, there are really no confounding variables to speak of around the effect of the parachute. We don't have to do a study to see if parachutes work. It makes sense. We don't have to study it in a randomized trial. And what the challenge we have, I think, in medicine is to determine, are we working on stones or parachutes? Those are the two sides. And the pathway that you are espousing, you have to make a decision at what point are these C variables, these type 4 confounding variable metrics, are they potentially influencing your outcome?